Good morning, everyone. My name is Devin Adams, Senior Analyst for Policy and Legislative Support at the American Cancer Society Cancer Action Network, or ACS-CAN. I'm excited to be kicking off National Minority Health Month with you and our panel of experts who have and continue to fight for health equity. I'll be moderating today's discussion related to the burden of cancer, disparities in diagnosis and treatment among Black Americans, and the role policy plays in addressing health equity. Cancer is a disease that does not affect everyone equally. Disparities exist along the continuum of care, from prevention and screening to survivorship. We know that cancer adversely affects groups of people who have systematically experienced greater social or economic obstacles and barriers to health care. In 2022, the American Cancer Society estimates that there will be over 224,000 new cases and over 73,000 cancer deaths expected to occur among Black Americans. And collectively, Black Americans have the highest death rate and shorter survival of any racial or ethnic group in the United States for most cancers. Additionally, Black Americans are more likely to be diagnosed with advanced stage disease, which is usually more costly and difficult to treat, more likely to experience delays in treatment, and less likely to receive recommended treatment. Although some cancer-associated genetic mutations are inherited, most health differences between population groups do not stem from biology, but from variations in socioeconomic status, variations in access to medical care, and structural racism, all of which are sources of health disparities among Black Americans. There are also disparities as it relates to participation in cancer clinical trials, as Black Americans are underrepresented in cancer clinical trials. Finally, we also know that the cancer care and cancer research workforce does not represent the US population demographically, with many racial and ethnic minority groups, including Black Americans, being underrepresented. Eliminating these disparities so that everyone has the just and fair opportunity to prevent, find, treat, and survive cancer will take thoughtful public policy and programmatic efforts that leave no one behind. And we'll be discussing some of these this morning. Before I introduce our panelists, we have some recorded remarks from Dr. Edith Mitchell of the Sidney Kimmel Cancer Center at the Thomas Jefferson University.
Good morning. I'm Dr. Edith Mitchell. I'm a medical oncologist at the Sidney Kimmel Cancer Center at Thomas Jefferson University in Philadelphia, where I'm one of the associate directors of the Cancer Center, and I am the founding director of the Center to Eliminate Cancer Disparities. I am also a member of the President's Cancer Panel. I am most appreciative of this opportunity, and it is my privilege to be here today to speak with you on a topic that is very dear to my work, and that is disparities in cancer care and healthcare in America. We all know that the National Cancer Act was signed by former President Nixon in 1971, and we recently, on December 23rd, 2021, celebrated 50 years of the National Cancer Act. Of note, during the 50 years, there has been a tremendous continuous decline in cancer death rates in this country. However, there are individuals who have been left out of the process. Non-Hispanic Blacks in America are disproportionately burdened with the most common cancer types, having the highest death rate of any racial or ethnic group. In 2021, approximately 1.9 million Americans were diagnosed with cancer. Racial and ethnic minorities accounted for a disproportionate number of these cancer cases, and non-Hispanic Blacks in particular have the highest death rate of any racial or ethnic group for most cancers. Racial and ethnic disparities represent a substantial portion of the overall mortality disparities between non-Hispanic Blacks and whites, and are a major consideration in the provision of clinical care and public health practice and policies. Racial health disparities are complex, and the causes have been identified at each step of the cancer care continuum, encompassing patient factors, provider factors, and healthcare system processes. The higher cancer mortality rate among non-Hispanic Blacks may reflect overuse or underuse, I should say, of prevention strategies such as screening. And this results in a later stage at diagnosis and underuse of cancer-directed therapy. Inequalities in the quality of care, including access to healthcare and receipt of recommended care, also contribute to the excess burden of cancer-related deaths in non-Hispanic Blacks. Non-clinical factors also play a role, such as structured racism and lower socioeconomic status. All are associated with unequal access to resources for cancer care and cancer intervention. All of these demonstrated to drive racial disparities in cancer. There are efforts to understand and target the causes of the observed differences in access, screening, and treatment utilization. And this is really critical to understand equitable treatment delivery and outcomes in all patients with cancer. Moreover, ongoing efforts to enhance the diversity in clinical trials and access to novel precision medicine initiatives are warranted to reduce healthcare inequalities. President Biden said in his February address regarding cancer in the country that a goal to decrease cancer mortality by another 50% in 25 years. And that is a reasonable goal that can be attainable. However, we must ensure equity so that marginalized communities as well as individuals have access to preventive measures, screening and early diagnosis of cancer, which allows for better outcomes. We need better diagnostic measures available to everyone. And that means participating in clinical trials, which allows for access to genomic testing as well as the newer precision medicine treatment. We must all work together and define our roles and collaborative work together to address the need to end the disparities across the continuum of care. As a member of the President's Cancer Panel, I speak with many organizations on what we can do and the many factors that were also outlined in the report that we, as the President's Cancer Panel, released in February, immediately following President Biden's address. So for more information, you can always call on me, and we can together develop collaborative efforts that will allow for understanding disparities in cancer, understanding what we can all do collaboratively to work together to end the disparities in cancer and allow for equity for all individuals in America. Thank you so much. I appreciate it.
Now I'd like to introduce our panelists. After their introduction, I'll invite each panelist to make some brief opening remarks, and then we'll turn to the panel discussion. I encourage the audience to use the question and answer function to submit questions for the panelists. Our first panelist is Congresswoman Sheila Jackson Lee, representing the 18th Congressional District of Texas. Representative Jackson Lee serves on 3 congressional committees: the House Committee on Homeland Security, the Budget Committee, and the Judiciary Committee, where she serves as chairwoman of the Subcommittee on Crime, Terrorism, and Homeland Security. She is also the founder and co-chair of the Congressional Children's Caucus, where she spearheaded the Bullying Prevention and Intervention Act of 2013. She has been a staunch supporter of legislation that aims to eliminate health disparities in the country, including providing health insurance for all Americans. Congresswoman Jackson Lee, I'd like to invite you to make some brief remarks. And could you please answer the question, what does health equity mean to you? Thank you.
Thank you so very much. And thank you for hosting this very important opportunity to speak about really a crisis in the African American community. Thank you to the CBCI for leading us off in the National Minority Health Month, and as well focusing on something that really is at the heart of the loss of life in and amongst African Americans. Again, I want to thank the CBCI leadership and Chairman Thompson, board members, and others for this great opportunity. I was speaking or listening to a radio interview with an African American woman who said her parents died of cancer, her aunt, her uncle, grandparents. It just was a chain of names that she recounted over and over again of persons who died of cancer. In my own community, I have taken the leadership role on insisting on the Environmental Protection Agency coming to a community, Fifth Ward, where Barbara Jordan, Congresswoman, the late Congresswoman Barbara Jordan, the late Congressman Mickey Leland grew up, where the toxicity of the railroad and the creosote, which soiled the soil, contaminated the soil, just created a cancer cluster of unbelievable proportions. When I went to knock on the doors to take a survey, every single door in that historic African American community with small bungalow home either had someone experiencing cancer right then or had someone who had died of cancer with someone in their family. So what we're talking about is how we find equity. The president has issued an equity order, executive order, to all of his agencies to deal with addressing the causes of inequity. And certainly part of that impacts the African American community. But according to the American Cancer Society, about 224,080 new cancer cases occur. 73,680 cancer deaths are expected to occur among Black people in 2022. Black people have the highest death rate and shortest survival of any racial ethnic group in the United States for most cancers. I've introduced the triple negative breast cancer in the National Defense Authorization Bill to enhance the research on triple negative breast cancer, which is one of the cancers that is most deadly for women of color, and particularly African American women and Hispanic women. In addition, for example, Black women are 41% more likely to die from breast cancer than white women, despite lower incidence of the disease. Part of that is that they get triple negative breast cancer. And we have put in over the years $10 million through each fiscal year, authorization year, to try and focus on that research, which is really among military women, but that research will then help others. Health equity is extremely important. And so I think what needs to come about is that we need to, as this institute is emphasizing, we need to develop and continue to push policy, as I've done, through legislation to respond to the issues of cancer. We know that, for example, African Americans are more likely to be uninsured. And I had to fight the fight with my colleagues against a state as notoriously bad as Texas is as relates to health care, refusing to take the expanded Medicaid. So we are the poster child for the numbers of uninsured Texans, predominantly in this instance, people of color and African Americans. It is most difficult to get care when you have no insurance whatsoever. And to note that in addition to cancer, 13.8% of African Americans reported having fair or poor health, chronic health conditions, and that is compounded when they have cancer. 80% of African American women are overweight or obese. That impacts if they're diagnosed with cancer. And then we find additional indicia dealing with mental health. In 2018, 8.7% of African American adults received mental health services, and that's low because of the stigma. So what I think is extremely important are several things. We must push for universal health care. In 2022, it is shameful that we do not have universal health care. We are looking in this administration, working with Congress, to expand to those who are uninsured. 12 states, legislation that I helped craft and push to ensure that those uninsured across the 12 states that did not accept expanded Medicaid would be able to access a federal health care program. That is in the Build Back Better program. And we hope to find pieces of that to pass. We saw President Obama come to the White House celebrating the Affordable Care Act, and part of that celebration was to give supplements or to give additional dollars to help people get under the Affordable Care Act. That doesn't really touch the levels of uninsured whose income is so low that they cannot, even with the supplemental payments, access the Affordable Care Act, which are managed care programs that insurance companies run. So where are we today with respect to the inequities in healthcare? First of all, let us accept it and recognize it. Accept it is not to hold it as a permanent feature. Accept it is to say it is a reality. It is a reality. We're uninsured in many instances. We don't have good health indicia, and we are susceptible by the neighborhoods that we live in, such as Fifth Ward, Texas, Cashmere Gardens, Texas, and I bet there are others in states all around, to the toxicity that would lead to cancer in our lives and in our family. And what we must do is to demand that those neighborhoods be cleaned up, that more super funds be added. We must demand, as I said, expanded health care. We must demand access to medical care by putting more community health clinics in our neighborhoods. Those are community health clinics sponsored by the federal government. And that's something that communities can raise up and organize around and put a proposal in to ask for a community health clinic, publicly funded, publicly qualified health clinic to be in their neighborhoods. They need access to primary care and mental health care. Then finally, let me raise this point. I have for at least a decade or more been carrying and working with first John Conyers and now leading the legislation myself, which is HR 40. HR 40 is a serious response to the across-the-board equities facing African Americans in 2022, and historically addresses the question of studying slavery and as well developing reparation proposals. These proposals deal with healthcare, education, sociological, psychological, political, and scientific inequities as relates to the African American community, starting from slavery and the emancipation. None of the impact of slavery has seemingly gone away. And so in crime, healthcare, education, economic wealth care, our wealth is $17,000 at most for a family of four that are African American, $151,000 for a family of four that are white. All of that plays into healthcare and its inequity. And so I encourage those who are joining us today to join me in pushing for the passage and the announcement of the existence of a commission that will hold hearings across the nation dealing with the inequities impacting the African American community. I will close on this. Johns Hopkins has already done a study showing that slavery and its impact, its dastardly impact, has transcended into 2022 in healthcare, nutrition, lifestyle that impacts African Americans today, and of course, the criminal justice system. So I thank you for having me. There are issues, problems, but there are solutions. And I always believe that we lift ourselves on the high note. We lost the dreamer this week on April 4th, but we didn't lose Dr. King's dream. And in us are the dreams, and we can propel them in health-wise and passing legislation, dealing with the uninsured, dealing with HR 40, the Commission to Study Slavery, and fixing the life conditions that will make us healthier and strong fighters against getting cancer, so that no one in the future has to be a grandchild that looks back to say that my parents, my grandparents, my aunts, my uncles died of cancer. They can say they may have had it, but they were cured, but even now they did not have it. That is the dream we should continue to have, matching with Dr. King's challenge to us that he had seen on April 3rd, 1968, the promised land, that he might not get there with us, but he knew that we as a people would get there someday. Thank you so very much for having me.
Thank you so much for those remarks. I'd like to call up or bring a presentation or a clip that we have from the National Black Caucus of State Legislators President, Representative Billy Mitchell of Georgia's 88th District, who has been serving his community in elected office since 1995. In his storied career, he was the first freshman legislator to serve as an officer of the largest legislative Black caucus in the nation, as well as the first freshman member of the General Assembly to serve on the Legislative Oversight Committee when he was first appointed to Georgia's Recreational Overview Committee. He's recorded this short message on behalf of the National Black Caucus of State Legislators, which we'll share right now.
So good afternoon, all. My name is Representative Billy Mitchell from Georgia, President of the National Black Caucus of State Legislators. Thank you for attending today's webinar, and thank you to all the panelists for your commentary and your insights on how cancer is affecting our community. NBCSL is committed to bringing awareness to cancer disparities, finding cures, and investments in affordability of medicines. Our group of over 700 state legislators nationwide come together each year at our policy conference to present resolutions that will help our communities. According to the American Cancer Society, due in part to the advances in medicines, the cancer death rate declined by 29% from 1991 to 2017, including a 2.2% drop from 2016 to 2017, the largest ever single-year drop in cancer mortality reported. However, out-of-pocket costs that are required by health insurers for innovative prescription drugs have been steadily increasing in the form of higher deductibles and co-insurance. Patients who are exposed to deductibles receive no benefit from their insurance plan early in the plan year to help reduce their health care costs. NBCSL believes that prescription medicines are a critical tool in preventing, treating, and curing disease, and believe that deductibles and co-payments must be reduced to make healthcare affordable and obtainable for all Americans. Furthermore, NBCSL recognizes that breast cancer is among the most commonly diagnosed cancer and the second leading cause of cancer death among women in the United States. Triple-negative breast cancer is one of many forms of breast cancer and accounts for about 15 to 30% of all diagnosed invasive breast cancer cases in the United States. More than 53,700 new breast cancer cases in 2019 in the United States were triple-negative breast cancer with higher prevalence among younger women, Black and Hispanic women, and women with type 2 diabetes or carrying excess weight in the abdomen area, and those with BRCA mutations. NBCSL supports legislation to reduce triple-negative breast cancer disparities in early detection and survival by improving education and awareness through health promotion initiatives targeting underserved communities, disproportionately impacted ensuring equitable access and affordability of breast cancer related care, services, and medicines along the entire continuum of care. In conclusion, NBCSL encourages our members to bring legislation related to cancer disparities, finding cures, affordable treatment, and medicine to their state chambers. We certainly will continue the conversations on cancer awareness and cures. Thank you, Amgen and CBCI, for hosting this webinar and allowing me to bring remarks.
Now I'd like to introduce our second panelist, Congressman Donald Payne Jr., serving New Jersey's 10th Congressional District. Representative Payne serves on 2 congressional committees, the House Committee on Homeland Security and the Committee on Transportation and Infrastructure, where he serves as the chairman of the Subcommittee on Railroads, Pipelines, and Hazardous Materials. Public health is an issue that is very close to Representative Payne's heart. He is the founder and co-chair of the Congressional Colorectal Cancer Caucus, which brings more awareness of this disease to his colleagues in Congress. He also introduced the Removing Barriers to Colorectal Cancer Screening Act, which was signed into law in 2020, so Medicare beneficiaries can get a polyp or cancerous growth removed covered during routine colorectal cancer screening. With that, I'd like to turn it over to Congressman Payne to make some opening remarks. And if you can address the question, what does health equity mean to you?
Thank you, Devin. It's really an honor and a privilege to be here this afternoon with all of you, and especially to my colleague, the gentlelady from Houston, Texas, Sheila Jackson Lee, who has been a stalwart in this area around health and health disparities. And I come to this area with a heavy heart. The reason I got involved in the colorectal cancer space is my father, the late Congressman Donald Payne Sr., succumbed to the disease. And I tell people that I probably came to Congress in the worst way you could possibly get there, the loss of my father. And so I really rather have him still be here and be the member of Congress serving the nation. But after his untimely death, I stepped up and to fill the void that was left by him. So a lot of my work has been of a personal nature because I really would hate to see many more people go through the pain and sorrow that I suffered in losing my father. And so it's been a labor of love for me to work in this space. And health disparities is something that we really have suffered from in this country for many years, as African Americans have suffered from so many different issues in this country. And it always seems that we're on the bottom rung of regardless of whether it may be. And so I'm not surprised that African Americans succumb to this disease at a higher rate than our white counterparts. But it is our obligation to do the best we can in order to make sure that people don't succumb to this disease. It is the second highest rates of death from any cancer, from this type of cancer, and it's the most curable. So that really doesn't make sense. It's the most curable form, but it is the second highest reason for deaths in cancer. So basically that's an issue of screening, education, and accessibility. my father, unfortunately, suffered from a stigma that we find in African American men with the actual test for the screening. There is a rectal examination, and we find that African American men are adverse to this procedure and just refuse to go through a quick rectal examination in order to determine the issue. So had my father gone through that simple test, and he was a learned man, he was an educated man, well-traveled, understood the complexity of many issues, but just would not take the rectal examination, and subsequently he died from the disease. And so, I really talk to men and I say, be a man and get tested. That really shows what a man is if you do the things that you need to do. But so many in our community and others, it's not just an issue for African American men, but it's kind of an issue for around all men. But that examination could be the difference between life and death. And so I fight very diligently in this space to make sure that African American men and men in general are aware of this disease and implore them to be screened. So I'm very proud to pass the Removing Barriers Colorectal Cancer bill I worked on for 4 years. And basically what it does is removes, basically what it said, it removes another barrier from people being tested. Because what happened with Medicare, you would go in for a colonoscopy routine checkup, and what they didn't tell you that is if and when they do the examination and polyps are found, that you would have them removed at that time, but you would wake up to a new medical bill that you had not, because they couldn't afford to find out whether they had polyps or not at that cost. And so it became a barrier to people being tested, hence the name of the bill. And as I stated, I worked for 4 years on that, and it finally passed, and Donald Trump signed it into law. Probably the only good thing I can say about him doing in his 4 years was the signing of that bill, because it helps save lives. So what the bill does is, if and when they have the procedure and polyps are found and they're removed, that there was no additional cost to the patient. And, that bill would be absorbed by Medicare and so Medicaid. And so I am very proud of that. It took a long time. Another issue that I'm going to address, and which I found out during this whole procedure, was going through the bill, was that there are a lot of laws that are on the books that private insurance companies are held to, that Medicaid and Medicare don't hold themselves accountable for. Now that doesn't make sense. The federal government should be setting the example, not avoiding the laws that we create and say, well, they don't apply to us. And there are quite a few areas that I'm finding this. So I'm going to be doing an overall look at the different bills that we have in place and make sure that Medicaid and Medicare are living up to the same levels of in the law that private insurers have to deal with. So I have several other bills that I'm working on in this area, and I'm really just delighted to be here to discuss these issues with you. So thank you.
Thank you, Congressman, and thank you for all your work in the colorectal space. It's been truly helpful and has undoubtedly saved lives. Lastly, I'd like to introduce Dr. Gary Parkerin, President and CEO of the nonprofit National Minority Quality Forum, which he founded in 1998. The forum addresses the critical need for strengthening national and local efforts to use evidence-based, data-driven initiatives to guide programs to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. Dr. Parkerin also serves as the Executive Director of the Alliance of Minority Medical Associations. I'd like to invite Dr. Parkerin to make some opening remarks. And if you could please touch on what does health equity mean to you?
Thank you so much, Devin, and great pleasure to be here with Congressman Payne and Congresswoman Sheila Jackson Lee, two great champions of healthcare, particularly in diverse populations. So the National Minority Quality Forum, we are a research and education organization based here in Washington, D.C. Most of our work is centered around collecting health data. We've been collecting health data now for 20 years. We have a database of over 5 billion patient records. We collect data on over 100,000 different conditions. So we can understand, in the case of colorectal cancer, we can drill down to the zip code level, look at the incidence and prevalence of colorectal cancer. We can aggregate it up to congressional and state legislative districts. So we work with Congresswoman Robin Kelly with the Congressional Black Caucus Health Brain Trust, and we try to share that information with members. We are particularly interested in cancer and colorectal cancer as well. There's some new screenings that are coming out. They're called multi-cancer early detection screenings. They screen for 50 cancers at one time, and they can find patients before the patient is actually symptomatic with a cancer. And that's incredibly important for minority populations, specifically African Americans. African Americans have the greatest number of cancer, incidence of cancer in the country. There's no population that has more cancer than African Americans, and they get diagnosed late for cancer. The Congressman unfortunately was talking about his father. It's not unusual. They get diagnosed late for cancer, and their survival rates are poor. So with these new multi-cancer screenings, there's an opportunity to do stage shifting, to shift from late stage diagnosis to early stage diagnosis of cancer. And what we're finding is the same thing that the Congressman found with colorectal cancer. There are rules and regulations that are going to make it difficult for minority populations to access these new therapies, new screenings, I'm sorry. And so we're at work at that, trying to break down those barriers. Health equity is really structured. We often forget, particularly in the healthcare space, that America was a segregated society. The healthcare system that we have right now was born during a period of segregation when inequalities and inequities were not only by custom, but were actually by law. And so the outward facade of that segregated society as it relates to healthcare began to come down in 1965 with the passage of the Medicare and Medicaid program, where the government insisted that hospitals desegregate, and later on the American Medical Association desegregated, and here we're talking about the 1970s. And the point is, a lot of that legacy system still exists. A lot of those inequities in care that came out of that legacy system still exists. So our work, and we're partnering with a number of other organizations around the country, is to reimagine our healthcare system, to reimagine a system where every patient who comes through the door the system is really there to help lower their risk for hospitalization, lower their risk for emergency room visits, lower their risk for disabilities, lowering their risk for dying. So we're excited about that work. We're using data to drive it. And in instances of like colorectal cancer, there's really an opportunity to reduce those mortality rates and provide better outcomes, particularly for diverse populations who have had just terrible outcomes from this particular cancer.
Thank you for that, for those remarks. With that, I'd like to invite all of our panelists back and just have a few questions to engage you and this morning. So my first question, and this is directed to both of you, cancer starts far before a person is diagnosed with cancer, and it's tied to elements found where people live, work, and play. These are commonly known as social determinants of health. What can Congress do to remove or surpass these barriers that would help to meaningfully address some of these social determinants of health that contribute to the higher rates of cancer in the Black community?
I'll start. So again, I go back to the history. I think we've got to understand where African Americans lived and the experiences that they've had in this country. For roughly 76% of our history in this country, we were either slaves or lived in a segregated society. It's only been 54 years since the passage of the Civil Rights Act and the Voting Rights Act of 1965. Our communities have progressed tremendously in that very short period of time. People forget how short that time is. And so our communities, still suffer from poor water, poor air, and the works that we're doing. All of them lend themselves to cancer. And part of the effort really is to clean up the environment around which we live. Like Congress can do a tremendous job at that, improve the air that we breathe. We all hear about the problems with water. And so all of those kinds of things contribute to cancer. And there's a tremendous opportunity for Congress to look at minority communities, particularly African Americans. One of the things that's not widely known is there are 38,000 zip codes around the country where people live. African Americans, 70% of us live in 2,500 zip codes. So there are really 2,500 zip codes around the country that we really need to fix and pay attention to. So it's not a huge problem. It's not boiling the ocean. It's really looking at very specific geographies and trying to make a difference.
No, that's shocking, the stat that you just mentioned on the zip codes. That's something that I've never heard that stat before, and it's something I'm interested in learning more about. And just kind of piggybacking off what you said, you mentioned in your opening remarks about data. I'm wondering if you could expand on how important it is to get accurate data to begin to solve some of the health inequities around cancer that we see in Black communities.
Healthcare, particularly population health, is all about the data. When you live in the data for a long time, you realize that it's highly predictive. In those 2,500 zip codes, we can predict the number of cardiovascular events that are going to occur in a year, how many people are going to go on dialysis, even the prevalence of cancer and the incidence of cancer, highly predictive. And so if you're able to use that data, have access to that data, you can begin to intervene. You can figure out places where we need to intervene and bring new resources. So data is everything when it comes to improving healthcare.
Congressman Payne, wanted to give you a chance to chime in if you have some remarks on that.
Yeah, situation in this country is dire in terms of the healthcare disparities that we see in the African American community. And it's interesting that Gary brings up the point about zip codes and how you can track different incidents of health disparities by zip codes. And it makes me wonder, as I was sitting here as you spoke about it, is there a predetermined effort to understand those zip codes and redline in terms of healthcare? It's been done in housing, it's been done in banking, it's been done in so many different areas. Why wouldn't it be done in healthcare? And so it's a very interesting point that you raised, Gary, about zip codes, that I had never really thought about it in that way. That's for another day, but that could be a very dangerous thought, that all of these issues that we face have some correlation to our zip code, and that zip code is used to make sure that certain folks don't have the resources, the clean water, all of these things. If I'm getting frightened that it would be that profound, that that's what they use in order to keep us where they want us. You opened a whole new can of worms, Gary. I you know, as you said that was really profound, and something we need to look at. You know, and I know a lot of times we shouldn't be surprised that we find ourselves in these positions. You know, our experience here has been, to be kind, challenging for generations, and it is just a concerted effort is needed in order to equal these issues out. I suffer from many of the ills that the African American community suffer from. I have congenital heart failure. I have suffered from macular degeneration because of diabetes. I have, right now, I'm actually fighting the 4th or 5th ulcer on my foot from diabetes. And I've been very fortunate to keep my toes. That's another area that I work in because of my interest in my own self, peripheral artery disease, and the you know, the work around stemming the tide of unnecessary amputations in this country. Once again, zip codes, and you know, we obviously find ourselves having the most unnecessary amputations in this country. And once again, it's because of the lack of understanding, like in this cancer space, screening and education in our community. To still be cutting people's feet and legs off in this day and age is unconscionable. When we know in other communities, they are revascularizing people's legs and being able to keep them. They open the veins back up to get circulation into the extremities. And in other communities, they're able to keep their limbs. But in our community, they continue to just lop them off and throw them out in the garbage. And I've done an extensive work in that area, and I've actually found that in Mississippi, there are zip codes that the hospitals within those zip codes are using amputations as the hospital's revenue stream. And what they're having is doctors coming along and knowing that the limb needs to be amputated below the knee, they don't do that because they're paid by the operation. And so they'll start with the toes and then do half the foot and then do the ankle, do mid leg, and then finally come to the knee because they get $1,500 for every amputation. So rather than knowingly do what they need to do one time, they get five shots out of it, and it's just criminal. And so I've been fighting in that area a great deal, along with my work in colorectal cancer. And we have a long way to go. Gary, you've identified, major issues in the area of health disparities. And we just need collectively as a community come together and continue to educate and make sure that people know about these screenings and get the health care that they need. I've been fortunate as a member of Congress. I have great health care, you can imagine. I have quality health care. But what happens to the young man in Newark, New Jersey, where I hail, that has the same issue, but is scared to go to the hospital because he doesn't have health insurance, and he allows the situation to go too long? Then his toes are turning color. So then he gets scared and goes to the emergency room. And the doctor running through there with 50 other people in there comes and looks at him and says, well, your foot has to come off, and goes to the next patient. Everybody in this country should have the response that my doctor gave me. We're going to do everything we can to save your foot. And that's what needs to happen in this country. And so, I will continue to fight in cancer and sound the alarm around these disparities in cancer and other issues. And, thank you for the opportunity to come on and hear from experts such as Gary and my colleague, Sheila Jackson Lee. And we've got a long way to go and continue to fight. So thank you.
No, thank you. Thank you for that question. And what your remarks about the medical system makes me think of another question and some research that I've seen. I've seen, studies that show that Black Americans have a higher mistrust in the medical system compared to others, and this is true in oncology as well. And we know that this is likely due in part to the long history of racial bias and discrimination in the U.S. healthcare system. So, what can we do to change, or how can we invest in the way we train medical professionals to better serve Black patients and Black communities?
I want to return to quickly, and then I'll go to your question, to what Congressman Payne picked up on zip codes. So life expectancy is tied to zip codes. We can predict your life expectancy by zip code, and obviously a minority populations, African Americans, their life expectancy is much shorter as a consequence of the zip code where they live. But we have the data. In fact, I was just working on a project that Congress will appreciate this, looking at hemoglobin A1Cs, aggregating them up to zip codes to see how well the diabetes is being controlled. So we can actually target communities where we see uncontrolled diabetes and reduce those amputations and cardiovascular events and kidney disease by being able to go into those zip codes, knowing the practices, knowing the numbers, and really pushing the campaign by the numbers. Quite frankly, I don't expect much from this healthcare system. As I said to you, it was born during a period of inequalities, and it still operates that way to a large extent. But we have to take ownership of the health of our community and move the resources along. I remember Congresswoman Christensen was thinking through a bill that was looking at health empowerment zones. We have the other empowerment zones, but you can use tax laws and a lot of different things to improve healthcare in those zip codes by creating health empowerment zones and making sure that there are clinicians and practices there, that they're well resourced. There's a lot of things that we can do, understanding where our communities live. I think the push right now is for us to build sustainable, healthy communities. That's where we are right now. Other generations had to deal with segregation and slavery. I think what's in front of us now is sustainability. How do we build sustainable, healthy communities? And I think we can use the numbers to drive that. I think we can get there.
And I'm sorry, what was the question again?
So I just wanted to highlight your remarks about the medical system and some of the inequities we see. I was just, if you have some thoughts on what can we do to change, or how can we invest in the way we train medical professionals to better serve Black patients and Black communities in America?
Well, we need to train more of our young people to go into those areas that have lived the experience and are sensitive to the needs of the community. And that would go a long way in helping close some of these gaps. There is a great organization that is trying to do just that. And pardon me, the name escapes me for a minute, but Micheline Davis, who is a great leader in the area of healthcare for minorities, is taking the helm of the organization that escapes me. The National Medical Fellowships, is one of the first diversity organizations in the country that's going to move us in that direction. And they are training and looking at the whole area about getting young people from our community ready for the jobs and moving into that area. And so I've been very supportive of Ms. Davis's efforts in there. And she just actually received a $12 million endowment for the work at her organization, and just really doing outstanding work, and is moving the organization forward. And I apologize for me looking away, but I'm trying to get the actual name of the organization, and I can't find it. Goodness. But what we will try to do is, later on send you the information so you can disseminate it about this great organization that is trying to prepare our young people. But that's one of the answers. More young people going into the medical fields and being trained to serve in those areas and really get the opportunities. And once again, the barrier there is the economic cost of an education like that. And so we need to work in that area to have more of our young people prepared for it. And I will get the name of the organization, because she's doing an incredible job in getting these young people ready.
No, thank you. Those are some very, very good points. You wanted to add to that, Dr. Parkerin?
I believe the organization is the National Medical Fellowship program.
Yes.
Yeah.
Thank you. Thank you. Oh my goodness. Gary, you've been a godsend today for me, I tell you.
No, thank you.
Yeah, Micheline Davis is taking the helm of that, and I think is really going to be a great leader for that. As I stated, she just was able to get a $12 million contribution to the work that she's doing there, and it says a lot about her leadership, and what can be done if you really are instead of not just talking about it, but being about it and making sure that we head in the right direction. Thank you, Gary.
Thank you, Congressman.
Well, it looks like we're closing towards the end of our presentation, our webinar this morning. So I just want to once again send a thank you to everyone who's viewing, and thank you to our panelists for such stimulating answers to our questions today. After this morning, I think we all have expanded our perspectives and understanding of public health and the ways that we can fight for better cancer treatment and prevention for all residents of the United States. So once again, thank you to our guests and our viewers, and enjoy the rest of your afternoon.